Welcome to Progenesis Academy webinar, session 31. Today's topic, does stimulation protocol affect egg quality? We are very fortunate to have 4 experts in the fertility and embryology field. We have Dr. Trolice. He's professor of obstetrics and gynecology at the University of Central Florida, also director of the fertility care, the IVF Center. We have Dr. Ivani. She is the IVF lab director at Reproductive Science Center of the San Francisco Bay Area. We have Dr. Dozortsev. He's the scientific director at Advanced Fertility Center of Texas, also president of the American College of Embryology. And we have Dr. Pomeroy. He's the scientific director at the World Egg Bank. Thank you so much for attending. Thank you so much.
Oh, our pleasure. Thank you for inviting us.
Yes, thank you.
Well, you know, today is a very exciting topic, a topic that we don't know a lot about, the egg quality. And I'm going to start my first question by how do you guys, and we have a physician, we have also lab directors, how do you define egg quality? And I'll start with you, Dr. Trolice.
Yeah, thanks, Nabil. Hi, everybody. You know, when I saw the premise of this talk, I started doing some more research on this because this has been a problem for all of us to try to determine. And I think that the question is part of the problem, is how are we really defining egg quality? If we look at many studies talking about gonadotropin dosage, total gonadotropin dosage, the outcomes are not consistent. Are we looking at oogenesis? Are we looking at fertilization? Are we looking at embryo development? Are we looking at blastocyst formation? Are we looking at blastocyst grading? What about aneuploidy? And then, of course, live birth. There are not consistent measures of what we consider egg quality, okay? And also differences exist in animal studies versus humans. In animal studies, it seems pretty clear that high dosing of gonadotropins impair oocyte quality in terms of more aneuploidy and decreasing pregnancy rates, as well as embryo formation and development. But the difference, I think, lies in human studies. There are pros and cons of what outcomes are being affected by high doses of gonadotropins, if at all. But I'm sure we can talk about that a little bit later. But I do think this is a vital consideration. And not to go too far into it, but I feel that there's enough information that we know high doses of gonadotropins, in other words, more than even 450 a day. But there's evidence to support 300 a day. There is no difference above that. And in the UK study, there was 200 a day. So I think that whether or not there is oocyte quality impact, if there's no difference over a certain threshold of gonadotropins, then we shouldn't be doing it for cost purposes, for risk of hyperstimulation to patients. And then what else about oocyte quality is there? Well, we also have the issue of the impairment of the endometrium. High dosing of gonadotropins, high levels of estradiol levels, and not as effective endometrium. Overall pregnancy rates with IVF, I think all of us would agree, are just not what we'd expect them to be, certainly this far out with IVF. And so something is causing the disconnect, if you will, for getting pregnancy rates as good as they should be, which they're not. And then you also have to consider getting involved. I mean, what is the impact of the other oocytes that were pushing to maturity that nature maybe didn't want to do that? Are there concerns of epigenetic phenomenon? Are there concerns of impacting mitotic spindles and chromosome abnormalities? All those different issues are still unexplained. But I you know, to cut to the chase, I think less is more. I think if we, you do the minimum amount of stimulation, that's going to yield a reasonably effective dose. And exceeding the numbers of oocytes that are reasonable in the 10 to 15 range. More than that, you're probably not really doing much of an advantage.
Thank you so much. Dr. Ivani, in the laboratory, how do you define quality of oocytes? I think you're muted.
When we're looking at oocytes, I was thinking about this as Dr. Trolice said, this seems like a kind of a simple cut and dry question, but really it's not, because it depends on what we're looking at. It depends on lab conditions. It depends on when we're looking at the eggs, who's looking at the eggs, how often we look at the eggs. I think we all have this sort of dream egg in mind that's a nice M2 oocyte with clear, smooth cytoplasm and a biorefringent zona pellucida and a normal polar body and a normal shaped zona pellucida and cytoplasm that's easy to inject. But oftentimes we don't see that. A lot of times we don't see that. And I think Dr. Trolice alluded to some of this, is it caused by the ovarian stimulation? I'm not, to some extent, I think that it might be, but we're all looking for that perfect egg, but I'm not sure that we can make a perfect egg. I'm not sure that there's so many confounding factors: patient age, the patient's diagnosis, lab conditions, the person looking at the eggs. And Kim and I had talked about, there's a couple of really great review papers for those embryologists who just can't get enough of this stuff. And we can talk about those in a little bit, but they literally both of those review papers looked at thousands of studies about egg quality to narrow it down to these factors that we see, and we don't often know what causes them. And most of the time, we don't have the luxury of getting the perfect egg. We have what we have, and we have to do the best we can with what we have.
Very good. But you still use the criteria you mentioned before: polar body, the zona pellucida,
right. That's how that's what we would look for. And I think, when we're training nurses and training new people, and we use the term bad eggs or ugly eggs or poor quality eggs, and they don't always understand what that is because they don't see the eggs, and we see them every day. So you see this huge variety of egg quality in just about every patient. There's giant eggs and tiny eggs and abnormal shaped eggs, and we would define the good quality egg as I described earlier. Yeah. But unfortunately, not everybody has a little bit of everything most of the time.
Yeah. Thank you so much. Dr. Pomeroy?
Yes. Go ahead.
How do you define egg quality?
Well, I think there's an ultimate definition of egg quality, and that's did it or will it result in a pregnancy? That's the best one, live birth. But we don't have the luxury of waiting that long. Why are we even trying to define egg quality? It's not that we're trying to pick the best egg as we are. That's how we define embryo quality. We define it to pick the best embryo, highest chance of implantation. But I would say that for egg quality, we want to know the egg quality of a cohort to see how it relates to how the stimulation has proceeded, to see if we can make a correlation between the physical features of the egg that we see, because we're not going to wait till pregnancy, and the stimulation that began to produce those eggs. Unfortunately, there's a lot of interactions, and those are the things that Dr. Trolice mentioned. You have to add onto that the age of the patient. Are they PCOS, or do they have other abnormalities? Were they collected with a lot of blood? Were they blood-free? I mean, there's a lot of things that can affect that egg morphology.
Thank you so much. Dr. Dozortsev?
Well, I agree with, I guess, I don't know, do you go by first name or by Dr. Trolice?
Whatever you like.
Okay.
Mark is fine.
Call me Dmitri, please. So it's easier anyway. Right. So I agree with Mark that the best, and actually with Kimball as well, that the best way and the right way to define equality today is retrospectively. If this egg is able to become a child once fertilized, this would be a definition of good quality egg. prospectively, there are markers, but in practical terms, we cannot use them. But as what is, I guess, most important is that even though we cannot define equality prospectively, we attempt to do this. And this is where we make a mistake. We define equality in practical terms, like in everyday situation, as an egg which has a polar body. And the goal of the stimulation becomes to get as many eggs with polar body as possible by at the same time mitigating hyperstimulation, right? Would it be fair? So this is what I can tell about equality. And of course, equality is without any doubts the most important thing which will define success of IVF in most cases.
Very good. Let's look at age effects. Dr. Trolice, does age affect the egg quality?
Well, we talk about ovarian aging, right? And we talk about two factors in that. Ovarian aging has two aspects to it. It has quality and quantity, right? Quantity and quality both go down as you get older. Quality is the best measure for quality is age of the woman. There's probably no better indicator of the likelihood of success of fertility other than the age of the woman. Quantity of the eggs is best reflected by anti-Müllerian hormone and the antral follicle count, okay? So those are the two ways that we look at it. And as a woman gets older, even if AMH is same as she is younger, I see that more gonadotropin is necessary to produce a reasonable number of oocytes. But going back to the points of stimulation, I think over time we have gotten more conservative, and it really is in the best interest of the patient. I mean, pregnancy rates have continued to increase over the decades, but over the last few years, though, they have sort of plateaued. Maybe we've reached the limit in the current technology. But high levels of gonadotropin dosages, we've had patients with hyperstimulation, which we can't dismiss the fact that that's a life-threatening condition. So we should always choose the least amount of medication that's going to give reasonable success. And then, of course, the impact on the endometrium. I hear colleagues saying, well, we just do freeze all. Well, I understand that to some degree. I mean, we know that freeze all data in a fresh cycle, and you freeze all and frozen embryo transfer cycles, particularly in hyperresponders, have been shown to be more effective. But there's a cost to that, right? Patients have to pay for another cycle involved. And not all states in the United States are mandating insurance coverage. So I think if we can get a reasonable stimulation and to do a fresh embryo transfer, that reduces the financial burden on patients, as well as the physical toll of having to go through 2 hormonal cycles on patients. So it's a continuing problem of knowing that you want to maximize the outcome of the cycle to a patient. And the instinctual response by a lot of physicians is, let's get as many embryos as we can, so we'll have lots of embryos to be able to transfer over time for frozen embryo transfer cycles, right? So if they have 1 child, then they have opportunities for more children, the more embryos that we have. Yeah, I certainly get that, but there's a limit and there is a risk to doing that. I've talked about it before. It's not a benign situation. It is super physiologic. So when you get situations that exceed what's normal in nature, we have to respect that and say, what are we doing harm in exceeding dramatically what is normal in nature?
Since you're talking about AMH and you talked about the intrafollicle count, we have a question from a patient on a chat from Elena. She's 39 years old, had 3 times IVF 1 year ago with AMH that was 0.48. Now she's 41 with an AMH of 0.22. Is it worth it to do another IVF cycle?
Well, AMH, the American Society for Reproductive Medicine and clinical experience tells us that it is not to be used as a cutoff value to proceed with IVF. We actually were fortunate enough to be involved in a pregnancy and a live birth of a 46-year-old woman whose AMH was undetectable. That, of course, is a rarity, and lightning doesn't keep striking, but it speaks to the fact that it's up to the patient to be able to make the decision about whether they want to go. Now, do I counsel patients who have a very low AMH level about the likelihood of success with IVF? Sure. Across all ages, AMH is going to have an impact on outcome because of, ironically, we're limiting the numbers of eggs, right? And particularly in the older reproductive age, the lower the AMH level, as well as the lower quality now because of their age, then puts us at significant compromise to outcome. But it's our obligation to empower our patients. And something that is important to underscore is the JAMA article several years ago to look at women who conceive spontaneously, and they compared AMH levels. AMH levels were age per age, whether the AMH level was low or what's considered normal for that age, same pregnancy outcome. So in natural cycles, AMH does not have that impact. And sometimes, particularly women well into their 40s, when they have a very, very low AMH level and their fallopian tubes are open and there's no male factor, you know, I share with them that I can't really tell them that IVF is cumulatively over time going to be more successful than if you keep trying naturally or even with IUI.
Thank you so much. Going back to age impact on egg quality, Dr. Pomeroy, what's your opinion? Does age impact egg quality?
You know, it depends on, once again, what we define egg quality as, but I think we can say it does, you know, age definitely does affect a pregnancy outcome, your probability for pregnancy, and it does affect the appearance of eggs, egg morphology. But like Dr. Trolice said, it doesn't mean you're not going to get pregnant. We have to look at probabilities. I think the biggest study that was done was a study by Sunkara et al. And this was with over 400,000 cycles. And they broke the stimulation up into age groups. And then whether they stimulated and produced few eggs or whether they produced lots of eggs, meaning 30 or 40 eggs. And in that study, if you look at especially the young group of patients, the pregnancy rate past about 9 or 10 eggs recruited was almost constant. So it's looking at the overall chance for pregnancy. But as the patients got older, you could see that the chance for pregnancy decreased. And you could also see that the percentage of patients that were in the producing higher number of eggs also decreased a lot. So, you know, I think it affects it. There studies have been done looking at granularity of the cytoplasm versus the age of the patient. And there is some correlation. But I really don't like to bring up correlation because too many people then think, well, then this is an absolute thing. And all it means is that it's related to it. But it may be related to it by, if we're looking at how well someone's stimulated, it may depend on more on whether they had PCOS or whether they were 40 years old. There are interactions there.
Yeah, thank you so much. Dr. Ivani, what's your opinion about age and equality?
Well, I think age definitely impacts egg quality, as we know from PGT studies, because we have obviously a higher incidence of aneuploidy with older eggs. If that's a measure of quality, again, you know, what is our measure of quality? Is our measure of quality, what is the endpoint? Is it fertilization? Is it embryos frozen? Is it implantation rate or live birth rate? It really depends on what your endpoint is. So, you know, we can have patients that have few eggs that morphologically look poor that do just fine. Likewise, we can have a patient with lots of eggs that look great that make poor embryos. So it depends, you know, what is our endpoint here. But I think most of the time, older patients are going to have fewer eggs and higher rates of aneuploidy, which by that fact alone one would consider those to be lesser quality eggs, but not to say that a patient couldn't get pregnant from those. But I think we need to be, as practitioners, really very realistic with our expectations for patients so they understand what their chance of delivering a live baby is, not even what their chance of getting pregnant is, but what their chance of delivering a live baby.
Nabil, can I ask a question of the group?
Yeah, of course.
So with PGT, and of course there's controversy in that, which we're not going to get into with the question, but as a woman ages, I don't feel that the chromosomal content of the embryo is the only reason that embryo is going to be good quality or not good quality.
Absolutely.
So I know that ASRM SART guidelines are single embryo euploid of any age. Does everybody still ascribe to that? I feel that the structural integrity of the embryo, the cytoskeleton, the mitotic spindles, I mean, there's so many other aspects of the embryo. Are people, or all of you rather, limiting your all age groups to a single euploid embryo, or do you consider more than one embryo well into the 40s?
Can I make a quick comment on that?
Of course.
The one thing that's left out is, are they developing to the blastocyst stage? Because I think if you look at the data, once you have a blastocyst stage from whatever age of patient and it is euploid, then the pregnancy rates are very, very similar. So it's a lot of those morphologies and structural defects that we might see in eggs from older people don't allow them to make blastocysts. And so that might affect the outcome.
Yeah, they're all blast biopsies, of course.
I would agree. I agree with you, Mark, in that the whole egg ages, not just the chromosomes, right? So everything in the egg is aging. But I know from our experience that if a patient has a euploid blastocyst, we transfer one regardless of age, and there's no statistical difference by age with one euploid blastocyst. So
it's already gone through the hurdles.
Pardon me?
It's already gone through the hurdles of making a blastocyst is one thing.
Right.
So that really differentiates it.
Yes.
Okay. So any age euploid, single euploid. Dmitri, you agree? I think you're on mute.
Well, I don't have an opinion on this one. I really don't. But if I can also take my my time, and I would like to build a little bit more on our definition of egg maturity as a marker of successful stimulation, right? Because this is our marker. And I would like to take a little bit different direction, which we did not discuss at all, and I cannot take full credit for it. It's based on a publication this year with Antonio Pellicer and Michael Diamond as the co-authors about term stimulation. And what I would like to throw at you is a kind of paradox. What if cytoplasmic maturity is a very early sign? I mean, maturity, I'm talking about polar body extrusion. Very, very early sign of egg competency. What if it is about the same as, let's say, sucking reflex in immature baby? So it's this reflex is developed at around like 35 weeks. And if we would define wrongly fetal maturity as time when fetus is able to have this reflex, and we would say this is a mature baby, we would have a lot of problems because we know it's not really a good marker of maturity, right? So what if this polar body extrusion is a very early sign of a competency? And in this case, this would be obviously a wrong marker for us to decide that stimulation was successful. And if we accept this as a possibility, and I think it's important to explore this further, if we look at fecundity in a normal population, not in infertility population, normal population, what we will find out is that that fecundity drops into half when the duration of duration of the menstrual cycle is going down from 32 days or 30 days to 26 days. And it's also important, I guess, to remember that the duration of menstrual cycle is determined by follicular phase. The luteal phase is very stable through the age groups, but duration of follicular phase becoming smaller. And in this article I mentioned, we draw a parallel to term pregnancy. When a patient comes to the doctor, he will not try to determine the delivery date by measuring her belly. We'll simply ask her, when was your last period? Because the time of pregnancy, duration of pregnancy, is much more important than how large your belly is. It's almost random. But during the stimulation, our marker is the size of the follicle, which you can arguably compare to the pregnant woman belly. It has, as we know, not much relation to the egg because it tells nothing about an egg. It's just a follicle which expanding irrespective of the egg because it has neural granulosa responding to FSH. And we have to trigger the patient when her follicle becomes too large. So there is a concern that she will ovulate or follicle will rupture, so that stimulation is stopped, right? And if we look at the duration of follicular phase, going back to the natural cycle, in a woman where she's the most fertile, let's say from 18 to 24, duration of the follicular phase is about 16.5 days from the day one until LH surge. So from day one to ovulation would be 18 days. But if you'll compare this to the duration of stimulation, it's always shorter than 16 days. I mean, not always, but almost always shorter. So, what we begin to think that perhaps the duration of stimulation that egg requires, just like a fetus requires certain time, you cannot shorten the time of pregnancy without consequences. And what we speculate in this manuscript is that perhaps we have similar situation with egg development as well, that it requires certain number of days, called term maturation, term stimulation, if it's a stimulated cycle. So this is just something I want to throw at you to see what you may think about it.
I'm going to take these points from here and then I'll cook it a little bit. So what you're saying in briefly is that with age, obviously, menstruation cycle decrease, the duration decrease, and that is a direct effect of the follicle phase that decrease as well. So that's what triggers the menstrual cycle to decrease over time with age. And you're saying that because the follicle phase is too short, it does not give enough time to the egg to mature. And that's why you get this infertility. Dr. Trolice, you have plenty of stimulation protocols that you use that may have only a short cycle, a short follicle cycle. Do you see that in real patients?
It's difficult for me to answer that. We know almost traditionally that stimulation with gonadotropins shortens the follicular phase from its natural occurrence. And when you have elevated estradiol levels, it could trigger earlier progesterone rise to advance the endometrium and throw that into asynchrony. So there is that negative effect on the gonadotropins. I think, or what I've seen clinically as well, is that in the diminished ovarian reserve patients, they have rapid follicle development. And that clearly is more likely to have immature oocytes, or even post-mature if you're trying to push them a little bit longer. So, to get a stimulation protocol for a particular patient, it's not one size fits all. and it is so individualized. For the patients who have rapid follicle development, we use leuprolide acetate to suppress and to slow down that development, to try to prolong a cohort of oocytes. The patient with severe diminished ovarian reserve, we actually do a combination of letrozole with FSH. There is evidence that I believe from Dr. Casper that the letrozole sensitizes the oocyte to FSH. The receptors are more sensitive, so we use that combination. But it's there's a lot of nuances in terms of stimulation about what is LH needed. How much is LH needed? Do you do baseline levels of LH and progesterone to determine how much LH is going to be added to gonadotropins? It's very difficult to accurately define the perfect protocol.
Very good. Dr. Ivani, when you're looking at when you're about to assess the oocytes, do you look at the stimulation protocol to see if you have any hints of what you're looking at, maybe triggered by certain stimulation protocols?
I have to be honest and say no. That's not necessarily my area of expertise. I think we have done, if we get a lot of immature eggs and we're not expecting that, then yes, we would talk with the physician about it. But I think more often, and I would love to know kind of what the group thinks about this. When we look at egg quality, are we looking at it because we're looking at it for an excuse for poor embryo quality or poor fertilization, or are we looking at it really prospectively? If we have a really poor cohort of eggs, we will look at the STIM protocol, but it's not something typically that I'm looking at all the time on every patient every day.
I would dovetail on that a little bit, that the patient with severe diminished ovarian reserve, we clearly do not push them for follicle growth. I'm interested to hear what you all have to say, but we will trigger earlier in those patients. We often will go 18 to 20 for most patients, but as we get into the older reproductive age, we'll start triggering when they start reaching around 17 with the lead follicles.
Kim, I'd be curious to know, if you don't mind, with your experience with the egg bank and so many centers that you're working with, to answer that question, because you're looking at eggs from a really different perspective. You're looking at the eggs that are going to be frozen. Not only are they going to be frozen, but they're going to be released to patients all over the United States to be used. How do you feel about that?
Remind me again what that is. Sorry, Kristen.
Do you look at the stimulation protocol for cohorts of eggs?
We do, but we have a very standard protocol that we use for starting all patients. And then it's just like in the standard IVF lab. If that donor comes back and they haven't performed as much as we would like them to, we might modify it. But a lot of those people, if they don't respond well to that standard stimulation, we just reject them overall as donors, because we can't spend the time and money to put them through more cycles. I should mention, I do think, and Dmitri brought this up and triggered this in my mind. And I thought your comment was very interesting, because there was a recent study that I read of, someone may know who performed it, I don't remember. And they looked at maturity of the eggs in the cohort, and then looked at such things like fertilization rate. And if the cohort had poor maturity, then the fertilization rate and other outcomes were poor. So that may have been, like you said, Dmitri, that they just did not get it through that right length period. And I would say when we stimulate, and I think everyone else has observed too, if someone has less than 8 days of stimulation, usually it means you're going to have a very poor outcome. And if someone has over 12 days of stimulation, it can also increase the probability of having a poor outcome.
Yeah, I think that when we talk about patients who had longer stimulation, we have to ask why she had longer stimulation, because it could be all kind of things. And if she doesn't respond then something is wrong. I mean, we're talking about patients who respond well, and then you can compare them to those who had shorter stimulation or longer stimulation, but not, with a cohort which doesn't want to respond. And I also want to get back to Mark. Yes, these follicles grow faster, definitely faster, about 1.5 times faster than during the follicular phase normal, which creates a problem because, as you said, in older patients, we have an issue with probably some ovarian cortex problems. So they tend to pop early, just disappear, this vanishing follicles, and then progesterone goes up, of course. Even if LH is suppressed, progesterone is up, so it's a concern. If patient has only one follicle or two follicles, this is it. So it's kind of between a rock and a hard place. You need to give your progesterone, but you cannot afford to lose the follicle. So it becomes very tricky to stimulate those patients, but doesn't, unfortunately, mitigate the fact that this shortened cycle may affect egg quality. So you have to do it, but it doesn't mean that it's good. And I think that maybe age is not so fatal. I just hope it's not so fatal as we think, based on our experience in IVF, exactly because of what we just discussed. Because maybe these patients who are older, and we kind of know this from minimal stimulation, which tends to increase the duration of the cycle, that this patient can do well if they receive time, because the stimulation is very gentle. So, and what I'm thinking that maybe this improvement is not because of the dosage of FSH, because FSH really can affect only, as far as we know, mural granulosa, not the egg, because egg has no receptors for FSH, so it has to be granulosa cells, and probably mural granulosa, because we don't have as many receptors on, corona cells or whatever's connected to the egg, which respond to FSH. So I think that maybe this improvement with lower dose of gonadotropins is due to our ability to extend the cycle a little bit. And this 1 or 2 days may sound like not a lot, but if you would put it in perspective, it's 2 days out of 12 days. It becomes a significant percentage of days. So, and based on what I saw, this cliff where pregnancy rate drops considerably is about 9.5 days of stimulation. 9.5, about 9 days for most patients. So I believe there is a cliff. But when the egg quality becomes optimal, I think that the best guidance for this is nature. If nature tells us, based on epidemiological studies, which have no bias about hormones or anything, if nature tells us that the patients who are the most fertile have the average, not follicular phase, but I guess follicular phase, because we count with until egg ovulates, so 18 days. It's statistics. It's very stubborn. It's reliable. We can bet on it, and we know that this gives the best chance of pregnancy. I would dare to say that this is what we should try to target in a controlled stimulation.
Very good. Thank you so much.
Can I just respond to something, Dmitri? Dmitri, all excellent points. I just wanted to go back to the progesterone. Of course, we know if we start seeing progesterone levels start to creep up, it's not necessarily ovulation. It's really not fully elucidated premature luteinization. So the fact that they start doing that, I would, if they are not where they need to be, I would continue. And then certainly for women above 35, just freeze at that point and not have to go. There is some evidence that women less than 35 with elevated progesterone, if you go to blastocysts, may not have as much of a negative impact, but I'm sort of a little bit concerned whenever we see elevated progesterone levels above 1.5 nanograms per milliliter.
Okay. Now I'm not talking about 1.5. I mean, your point is well taken, Mark. I'm talking about patients who have progesterone 5, 10, when follicle pops. Like
Oh, I
older
see,
patients,
I see. Yeah.
LH is suppressed. There is no LH problem, and if she has only one follicle, this is the end. This is all I'm saying. But if she has more
Right.
follicles, then I agree with you. This patient, and it's a freeze-all cycle. There are no reasons to stop the cycle. Of course, I mean, progesterone will do nothing to the eggs. It will just, act on endometrium, and you can safely ignore it completely and continue stimulation until you get to desirable trigger time. But apparently, this what we call vanishing follicles, what I'm talking about, where follicle completely pops, and then you have luteinization without LH, which is another different interesting question, because you have no LH, but you have luteinization, yes. And so I'm talking about those patients. And by the way, the hypothesis, which is not my hypothesis, it's a hypothesis by a physician from Israel. I believe his last name is Cole. He hypothesized that it happens because in older patients, or maybe some patients, but definitely older patients, the cortex is losing elasticity. Just, as woman ages, she's losing collagen all over her body, and not only externally, but also internally. And as a result, it can't accommodate normal expansion of the follicle. And as a result, she's prone to have these follicles popped too earlier. It's a mechanical process. It's not driven by hormones in this case, even though we see this manifested as hormones, but the underlying problem is not hormones. And then I would extend his speculation about the cortex, that it's possible, just possible, that this shortening of cycle, which is seen with age, may be due to also mechanical reasons, changes in cortex, because we know that hormones of themselves don't explain completely the ovulation. You need to have something else. Like, we believe it's inflammation within the follicle, it just precedes ovulation. And perhaps it just happens earlier as tissue age, and this reduces the duration of the cycle.
Very good. So I'm gonna share with you guys one piece of data we have. Riley, if you can help us put the slide on egg quality. We have looked at how people score egg quality, and we have M1, M2, and JVs. And what we see is, when we look at egg donors, this is the data from more than 19,000 oocytes that were scored. If you look at egg donor, 12.15% were JVs, 532% M1s, and 85.52 M2s. If you look at patients over 42 years old, the rate of GVs increased almost double to 21.83%. And then you have approximately the same rate of M1, and the rest are M2. Dr. Pomeroy, do you see this same distribution? Do you have any idea whether older patients have more GVs? Have you tracked that information?
Well, of recent at least, I've mainly been dealing with egg donors. So I don't know, and I can't remember. I have always wondered, though, why we would get different concentration, different percentages of M2s to M1s and GVs. And it's never made much sense to me. Does it have to do with the timing of the trigger? Is it how long they've been on gonadotropins? What is it? And as Dmitri was speaking earlier, maybe it is somehow related to the amount of time that they're on gonadotropins and the level of those gonadotropins. But I really don't know. I don't have a good answer for this.
Very good. Dr. Ivani, do you see such a distribution, or have you noticed in your population of oocytes that age does affect the rate of GVs, increase the rates of GVs?
I've not noticed that specifically, but I think the points that Kim and Dmitri make are really valid. With donors, it's a much more homogeneous population that you're working with, and a 42-year-old can be a youngish 42-year-old or an oldish 42-year-old in terms of response to stimulation. So I've not noticed any higher incidence of GV eggs with older patients, no.
Yeah. So can you for a moment define for us what GV for those that are not, you know, familiar with the term, how those GVs look like on a microscope and maturity wise?
A germinal vesicle egg is what we would consider an immature egg, and it generally has a little bit darker cytoplasm. It has the germinal vesicle is really very obviously present, and it looks like almost like
Right.
yeah, almost like a pronucleus in the center of the egg, just one. But they typically, like I said, have darker cytoplasm, and we don't use them. I know there are studies doing in vitro maturation of germinal vesicle eggs, but we discard them. We do not use them. Yeah.
What about Meta 1s, Kristen?
We will, so a metaphase 1 egg, you no longer see the germinal vesicle, but it's not excluded, extruded the first
Right.
polar body, for those people who don't know what GV and M1 eggs are. And we would consider that an intermediate maturity egg. We only will inject those eggs. Our program, we do 90+% ICSI, so we do evaluate those eggs. We generally will only inject the eggs if the patient has a small number of eggs. If they have a large number of eggs, we discard them.
Why so much ICSI?
Well, I think there's a lot of reasons. We do a lot of PGT in our practice, and a lot of that, honestly, is patient-driven, not necessarily practice or physician-driven. Patients in our area are very interested in transferring a single euploid embryo. And those of you who are in the olden days of doing PGT, when it was just PGD, ICSI was recommended, and I think that's kind of a holdover for that. We know now that it's not necessary for that. Right. But I do think that doing ICSI allows us to avoid, for the most part, those unexpected poor or no fertilizations. It gives us an opportunity to look at the egg quality and have some speculation for the patient and the physician about the quality and maturity of the eggs. Because when you're doing conventional IVF, you don't necessarily have that information as clear and accessible.
So since, I'm sorry, Nabil, this is not obviously the part of the talk, but since ICSI is not going to improve fertilization on poor egg quality, are you using it by saying that failed fertilization with ICSI is an egg quality?
Well, more an egg maturity, I think, more often an egg maturity, but it definitely can be an egg and sperm quality issue that ICSI is helping.
If I can just insert myself for 1 second, I would like to make a comment since we talk about PGS in this Progenesis symposium. We have to talk about PGS. I think that it's better not to separate egg quality and chromosomal errors in embryos. I believe that both are just different. Metabolic competence can reveal itself as chromosomal errors. It's not some separate phenomenon in the eggs. It's just a lack of competence, and this competency will reveal itself as a poor development or chromosomal errors, usually both. So that would be my comment on this one.
Yeah.
Well, we can't. I'm sorry, Nabil. We can't exclude the male factor. You know, we know that there's more information that men probably 40, if you want to use that age cutoff, are going to have higher infertility, higher miscarriage, and increasing birth defects. Some autism, schizophrenia is higher, and preterm labor in the partner. So if the miscarriage rates are higher, then we have to be presuming that there is contribution of the male age to potentially aneuploidy.
Absolutely. No,
hey, Nabil?
Yeah, go ahead.
Would you like me to show some pictures of some odd-looking eggs?
Sure.
Some what might be poor morphology eggs?
Absolutely.
I should mention, I think these are taken from Laura Rienzi's paper, which is an excellent paper that is a summary of egg morphology. I know one of the participants has asked about this.
Sure.
So
are you able to share the screen with us?
Yeah.
Riley, can you?
I've got it.
Oh, perfect.
Can you see it now?
Yes.
So if you see this this A egg, you can see the polar body here. You can't, if you look here, it's very grainy. So this is what is called diffuse granulation of an egg. This egg here, the central part, egg B, where the arrow points, it looks like an indentation in the egg. And this is where you have a central granularity in the egg. If we look then at C, there are a bunch of smooth endoplasmic reticulums here, little tiny circles. And this is what we call SER eggs. They oftentimes, people feel that they might have problems with them. And I've actually found if I avoid doing ICSI into those SERs, they survive a lot better and I have a better probability of fertilization. This D egg is highly vacuolized. These usually do very terrible, lots of fragmentation if they make an embryo. But some vacuolization doesn't appear to harm the egg or affect its quality. This is something, believe it or not, that is not that uncommon. Seeing an abnormality of the zona pellucida, either a pinching out like this, or sometimes you'll see that one part of the zona pellucida, because the zona pellucida has layers, one part will be here and the other one will be sticking out almost like a herniation. So that's abnormal zona pellucida. And this one looks in this space here. I don't know if on egg F, if my pointer's showing up, but my hand shows the paravitelline space. And in here, you can see there's a lot of debris. There's the polar body there and all this debris. And so sometimes people look at where there's debris in the paravitelline space and how wide this paravitelline space is. Most studies show that this does not affect the quality of the embryos. Most people will look at the thickness of the zona pellucida, and most studies show that thinner zona pellucidas have higher fertilization rates, but they don't seem to affect the quality of the embryo. Even a dark zona pellucida, which we don't have an example of here, it does not seem to affect the quality of the oocyte as measured by embryo quality.
And when it comes to blastulation, euploidy, implantation, and all that, what would be your favorite ones to choose from that picture?
None of them. I mean, if I had to choose one, I don't like the granularity. I don't mind misshapen egg, and I've seen beautiful blastocysts from misshapen eggs. So abnormally shaped eggs, that's probably the one I'd hang my hat on.
Very good. We don't have any studies on outcome and egg shapes and morphology and outcome.
Oh, yes, there are. That's what the Laura Rienzi paper has. And there's about 3 other papers, one by Ebner in 2006, Swainenpool in 2008, and Ozturk in this year, 2020. And these are all review papers. So they look at what other people have done. And on some of those factors, they look at outcomes. But it's so difficult, especially if you're not transferring one embryo, then it's impossible to tell if there's correlation. So they have looked at those outcomes, but I think what's given us more information really has been looking at embryo quality, the number of blastocysts that are produced.
It would be nice if you could track the stimulation protocol for all this morphology that you're looking at.
Oh man, there are so many little tweaks to the stimulation protocols. That would be, they'd all be different.
Exactly, it's not possible. This is what people are trying to do. That's why it always come as a result as maybe, you know, maybe, because it's impossible. You know, you cannot do it this way. You can only do it prospectively when you know what you're looking for, and go in a fishing expedition by going back to the already done cases. Looking at them is usually not going to give you a meaningful answer, or actionable answer, better to say. But you know, what I would like to comment on those morphology, or ask you rather, the egg which was A and egg which was D, would you say those are post-mature eggs or not, in your opinion? what we describe as post-mature.
So you said A.
Kim, maybe you
Oh.
can post the images one more time so we can look at
Okay.
your.
Yeah, it was A, B, C, A, and D, like the one with vacuoles, and the one above it, which had this granular cytoplasm. The SAD, yes, exactly, yes,
Yeah.
AD.
So here's A.
Yes.
And, you know, this is my gut feeling, and that's what most embryologists work on. And I hate doing that because I'm a scientist. I want to see data. But this egg A, I would say, is post-mature.
Post-mature, okay.
Either that or it's seen a lot of gonadotropins.
Okay, maybe both, but
Yeah.
but gonadotropins probably the cause, but you know, it's okay. And this one D, do you think it can also be post-mature or not?
Okay. Well, A, when you see this, oftentimes it affects a whole group of eggs, the whole cohort. When you see these vacuoles, you see this sometimes, you know, on just one egg out of a group.
Okay.
I don't know. I've noticed this one has a very small polar body, but I cannot guess. What do you think, Dmitri?
Well, I was going to ask you a question. What do you think about origin of post-mature eggs? Because I have my own hypothesis, but it's just a hypothesis. I think that post-mature eggs is a very, very important phenomenon, which is underrated. We describe eggs. We can't even really just define post-mature egg. As you said, it's based on gut feeling. People would say it's post-mature. There's no clear criteria. What we can say about this egg. We can say about this egg this, okay? This egg looks like an egg which spent in culture more than 24 hours. Because if you leave it in culture, it ages and it will look like this. Any egg, any normal egg, you leave it for 48 hours, they will all become like this. And that's why either vacuoles or, you know, this cytoplasm. That's why I believe you are right when you describe them as post-mature. Because post-maturity, if you think about how it happens, it means that egg maturation was triggered before the trigger. So egg remained in follicle even though it was already beginning to mature, so resumed meiosis. And it can happen, as you know, if follicle, as Mark told us, sometimes this progesterone goes up, 1.5. Why it happened? The only reason for progesterone, I mean, we assume for now, is the follicle. So the progesterone has to come from the follicle, right? And it can only come from the follicle if follicle begins to luteinize. There are no other options. We can't even imagine anything else. The follicle begins to luteinize, one or maybe two follicles, not all the way, but it begins to luteinize. And when follicle milieu changes, we know that the egg will resume meiosis. If we remove the egg from the follicle, when we change the milieu for the complex, it will tend to resume meiosis. So what I believe happens when we see that progesterone goes up a little bit, we have to assume that some of the follicles started to luteinize spontaneously. It can happen. And as a result, egg resumed meiosis. So by the time when it's retrieved, it's 48 or 72 hours old, it looks like an old egg. So this egg is post-mature. And you can also, I'm sure you noted that, you can also have post-mature German vesicles, which look like post-mature eggs. We all saw them. It's a egg which is obviously immature. It has a GV, but its cytoplasm looks like it's cytoplasm from a post-mature egg. What happened when this follicle popped where this egg was located, it wasn't ready to resume meiosis. So it remained as GV. However, it was dying within the follicle. So when it was retrieved, it was post-mature. This is a hypothesis. Okay, this is a hypothesis. But since we talk about post-mature eggs, I wanted to tell you about this idea and ask you what you think about this.
Yeah, so talking about post-mature eggs, Dr. Ivani, there is a comment in the section by Aaron that said that when you do an ICSI, it feels more soft. There's no resistance. What do you guys think about that?
How do you know it's a post-mature egg? I think that's, I hate to say it, but I think it's someone just assuming that. Okay. You know, we don't know when we have an egg, we don't know what size of follicle it came from. And
Right.
if it came from a larger follicle, and maybe a 25 millimeter follicle, maybe that would be post-mature follicle. But when we don't even know how to measure post-maturity, how can you come to that conclusion?
Dr. Ivani, can you tell when you have an oocyte that is potentially post-mature?
I don't think so. I agree with Kim. I think that, you know, we don't know where the egg came from, which side it came from, how big a follicle it came from, you know, unless you're in a practice that tracks that egg by egg, which we do not. I think these review papers are really excellent in that they cover every type of morphological characteristic of the egg, including the soft membrane, no membrane resistance, or cytoplasmic viscosity. And what they've shown is that oftentimes the fertilization rate may be different, but it all comes out in the blastulation rate and pregnancy rate. And really in all of these morphological characteristics, there was very little difference in the pregnancy rates and the live birth rate, you know, where you might see differences in fertilization rate. And I think there's just so many confounding factors. So in a patient on a high dose of stimulation is going to have different eggs than a patient on a low dose of stimulation. And it's going to be age related, and it's going to be, there's going to be culture conditions that affect this. So it's the only way we could know this going forward is if we did a prospective randomized study and you had patients that were similar characteristics on similar stimulation protocols, similar ovarian reserve, and you looked at the eggs that came out. I think otherwise we're just shooting in the dark. And I think we as embryologists, we get what we get, as I said at the very beginning of this, and we have to make do with what we have. We have to do the best we can for the patient with the eggs that we get.
Yeah, I agree that we have to do the best for the patient, for a patient, but I respectfully disagree that we cannot. We can say it is a post-mature egg without any questions, because that's why we have this idea about post-mature eggs. We all saw them, and also what I can tell you that we did a little study, not published study, but we looked at patients who had this elevated progesterone, slightly elevated, and not because when it's very high, then you lose the follicle. You have progesterone, 9, 10, so there is nothing in the follicles, completely luteinized, it disappeared, it vanished. But when the follicles do not disappear and you have elevated progesterone, you can look at the follicles, and what you find if you do specifically this kind of investigation and you know what you're looking for, you will find that in patients who have elevated progesterone, about 1, I would say, just to give some reference, you will find 1 or 2 follicles from which you get complexes with apparently dead cumulus cells. And we all know that sometimes the cumulus cells look very nice, like a cloud, tight cloud and everything. And sometimes you can see that major pycnotic, kind of dark and degenerated. And anecdotally, of course, we didn't publish it, so I cannot say that's 400%, but we did see that in those cases, we find 1 or 2 eggs which would be post-mature in appearance, and they came from follicles which had dead corona and cumulus cells. And dead cells look very different from cells which responded to HCG. They are dead. HCG doesn't kill cells. It disengages cells from the egg, but it doesn't kill them. When you see dead cells in the cumulus, you know something wrong has happened, and you can see it very clearly. In my mind, there are no question that eggs can die within the follicle, and we can still get them from the follicle. They will be different from all other eggs, and I believe those are post-mature eggs.
Thank you so much. I think we're getting closer to the end of the webinar. I'm going to just ask one more question, final question, especially for you, Dr. Trolice, is what is the takeaway from this as far as adjustment of stimulation protocol? If I know that you've gone through that exercise already, how would you handle cases where you may think that is either too early or too late when it comes to managing the cycle, the stimulation cycle, and the dose, of course.
Well, nothing beats a prior IVF cycle to help you with the next one, right? We don't always have that luxury, but if anyone's ever had a prior IVF cycle, it really is in the best interest of the patient, for the clinician, to get those records and to study them and to see what type of impact stimulation had, numbers of mature oocytes, and so on. The takeaway message that I would say is that less is more. And there is no justification to give the high dose stimulating gonadotropins that we used to do in the 80s and 90s, maybe even in the early 2000s, for two reasons. One of them is that there is lingering concern over the impact on oocyte quality, however we want to define that. But there is also no evidence that exceeding some UK is 200 IUs. Baker had described no more than 300 IUs a day, 3,000, above 3,000 total for the cycle, reduced outcome. It reduces the risk of hyperstimulation. It reduces the cost to the patient. And if there's no difference in outcome, there's no reason to exceed that.
Thank you so much. Dr. Pomeroy, takeaway message for embryologists or embryology equality?
Well, I agree with Mark. I would add one caveat, and that is I do not feel that there is enough evidence to promote minimal stimulation over standard stimulation, that minimal stimulation does not result in better eggs or better outcomes. I think it's an excuse more than anything to spend less money on a cycle. It's not cost effective.
No, I was not at all considering.
Several studies too that I can.
Yeah.
I know.
But
That you need about at least 10 eggs from a cohort to have the best chance for pregnancy.
I think minimal stimulation is marketing to some degree,
well, I guess it's like everything in medicine, right? You must have indications. That's why, we don't do PGS on everybody. It's also, you have to have indication. It won't help everybody, right? So, and minimal stim, if you have a choice, then obviously you want to get more eggs. But for some patients, I believe that it helps. But expanding it to everybody and marketing it to everybody is a better way to get eggs. Of course, I agree, absolutely, it's wrong. But some patients would benefit from it. So I'm sorry, it wasn't my...
No, take your turn and then tell us what the takeaway message. I know that you probably hint on how to help cases of patients who have, for example, a short follicular phase. How do you handle that from a medical perspective?
Well, what I would say, not my necessarily takeaway message, but my, I guess, my message. My message would be that I think it's important to start connecting clinical and laboratory information in a meaningful way. I truly believe there is a gap in most cases in reproductive endocrinology and embryology. So that this what we saw, that embryologists don't tend to look at stimulation. They don't feel comfortable doing that. But at the same time, physicians, even with their own IVF laboratory, it doesn't make them expert embryologists if they talk about it. So it doesn't. So, if you own a Paganini, violin, it doesn't make you Paganini. So, and I think that it's important to begin recognizing this fact and connecting physiology and observation in IVF laboratory with clinical observation in a way which tries to explain what happened. This would be my message.
Can I extend your thought, Dmitri?
Yes.
Since you extended mine,
okay.
So I'm going to extend yours.
Okay.
We also need to add, we need some finances. NIH needs to start trying to support some of this work so that we can have good studies that are not just retrospective, so that we can do some prospective studies and find out what's going on during stimulation.
Absolutely. Amen.
Ivani?
I would echo more is not necessarily better. more drugs, more stimulation. And I think for those of us who've been doing this a really long time, you know, we think about back in the early 90s when, you know, to a patient, especially to a recipient of donor eggs in a non-mandated state, more was better. And this, you know, their idea of cycle success was to have a boatload of embryos frozen. And we know now for many, many reasons that that's not a great idea. Stimulation, and having the trauma of having all these leftover embryos. And it's clearly been proven by egg banks where we can now purchase a lot of 6 or 7 frozen eggs and have a great chance of pregnancy, live birth, with oftentimes embryos left over to freeze, but just 1 or 2, not 15 or 20. And I think that that's, you know, the one healthy baby is really what we're trying to get at. And I do think that if we had the opportunity to do prospective studies where we could look at these instead of, you know, looking at everything after it's done and trying to figure out why it happened, which is what we still do. We look at a patient's cycle at the end and they didn't get pregnant or they didn't have great embryos. What are we going to do differently for the next cycle? It would be really nice if we had the opportunity to know ahead of time how best to treat a certain type of patient. But it's just really difficult.
Yeah, no, excellent. No, that's you're exactly right. Thank you so much, Dr. Ivani, for your contribution. We are getting close to the end now. I would like to give you guys a minute to introduce your practice, and then with that, we will wrap up. And I'll start with you, Dr. Trolice.
Thanks, Nabil, and thank this wonderful panel. I learned a lot as last time, and it's always an honor to be part of this kind of a evening event. I'm director of fertility care at the IVF Center in Orlando, Florida, and our website is theivfcenter.com. And so it's once again, it's my passion to be involved in educational events for patients as well as colleagues.
Thank you so much. Dr. Pomeroy?
Yes, I'm the science director at the World Egg Bank, and we are one of the longest running egg banks in the United States. And our model for how to provide eggs is different than anyone else's because we do everything within our own laboratory and clinic. And I just got to thank everyone. I've got to say, especially Dmitri, you said something that really got me thinking along a different way. And I think that might help me in looking on how to stimulate patients in the future. So thanks, everyone.
Fantastic. Dr. Dozortsev?
Okay.
Dmitri.
Oh, yes.
Your turn.
Kimball, maybe we can work together on some of the projects, and the same for Mark and Kristen. You know, it would be interesting to see. Maybe, you know, we can only meet each other in a panel, but also in some research project would be interesting because you know what the commonality is that we're all curious. We want to know the truth. So that's why we spend time in this conference. And thank you to Nabil. It's remarkable he manages to have these forums every week, almost every week, and I appreciate that you give this podium to me. What I would like to do is to invite audience, those who are interested, to look at American College of Embryology website. It's embcol.org. The college is actually trying to create more and more people who are able to interpret observations in laboratory within the context of patient's history. And this is very important, I believe, approach for the future of IVF. I truly believe there is a gap in knowledge which has to be filled by somebody, by people. So thank you once again to all participants. It was very stimulating conversation.
Thank you. Dr. Ivani?
I would like to extend thanks to you, Nabil, and to Riley and Progenesis Academy for continuing to put on these really amazing and timely topics. I'm the laboratory director at the Reproductive Science Center of the San Francisco Bay Area, which is in San Ramon, California. We have a 7-physician practice with 4 office locations, and this is my 31st year there as lab director. And I'm happy to say that every single one of these, I learned something new. I love meeting these new people. Kim, I've known longer than that, I have to say. But it's just such a great opportunity. It's an incredible field, and I feel very fortunate to still be excited by it. So thanks for letting me be a part of this.
Thank you so much. Well, we are coming to the end of the webinar. This is the last webinar for 2020 as we approach the end of the year.
Oh, please no.
Early next year, we will have, we'll start a webinar starting with fertility options after 42. Then we're gonna have another topic on 3 parents IVF. With this, I would like to present my gratitude and appreciation for the work that you do and for the dedication that you have for patients. Thank you so much, and I will see you next year. Happy New Year and happy holidays. Thank you so much.
Same to everybody. Happy holidays.
Thank you.
Stay safe.
Be safe for sure. Bye-bye.